I'm Amber Tresca, and this is About IBD. I'm a medical writer and patient educator who lives with a J-pouch due to ulcerative colitis. It's my mission to educate people living with Crohn's disease or ulcerative colitis about their disease and to bring awareness to the patient journey. Welcome to episode 141. Look, there's never a good time to receive a diagnosis of IBD, but being diagnosed when you are an active member of the U.S. military brings some specific challenges. For some, it may lead to being separated from service. Now, that could be for a lot of different reasons, including the need for treatments that are infusions or injections. However, there seems to be a sea change taking place in recent years. One factor is that there are now more options for treatment that are oral medications. Plus, the understanding of IBD is increasing, and with more effective treatment options, some people may find that their disease is better controlled overall. My guest is Dr. Anish Patel. Dr. Patel is the medical director of the Inflammatory Bowel Disease Center at Brooke Army Medical Center. He is also the only formally trained IBD specialist within the Department of Defense. He explains the challenges of managing IBD during active military service, how he helps people stay in the military once they're diagnosed, and he offers some tips that anyone living with IBD or chronic illness needs to hear. Dr. Patel, thank you so much for coming on About IBD.
Oh, thanks again, Amber, for having me. I really appreciate it.
Oh, it is my pleasure. Absolutely. So I wonder if you would start by introducing yourself.
Sure. My name is Dr. Anish Patel. I'm actually an active duty lieutenant colonel in the U.S. Army. I'm currently the director of the Inflammatory Bowel Disease Center here in San Antonio at Brooke Army Medical Center. And I have the opportunity. I'm the only IBD trained person in the U.S. military. I got trained in Mount Sinai around 2015 and 16 is when I got trained in it.
And Dr. Patel, that was actually my first question for you. I read that.
Thank you.
That you did. You lapped me there. That you are the only formally trained IBD specialist within the Department of Defense, which I found absolutely wild. So I wonder if you would start by telling us, why did you decide to make this your focus?
Yeah, it's funny. My fellows always ask me this question too. Every time they see IBD patients or in clinic, the first question they ask is, why did you do this? And it's not to be offensive to any IBD patient. It is a difficult field. I mean, patients are complicated. They're really sick. I think it was a niche need. When I graduated fellowship in 2013, I actually wanted to be a liver specialist. I actually wanted to be a hepatologist. I was, geared towards that, ready to go. Right the day before, so the military does like a matching system. Right the day before I pulled my application. I said, you know what? I don't know if I want to do liver for the rest of my life. So then I spent like a year up at Fort Cavazos, which is now known as previously known as Fort Hood, and I saw a lot of IBD patients. I mean, to the point where they're getting mismanaged. I mean, civilian network, wherever they're at, we're getting really mismanaged. I'm like, you know what? This is something, especially active duty soldiers. I mean, people that, I put the uniform on for a reason, to help these people. And they're coming in like miserable, sick. And I was like, I started liking it. Once I started helping them, getting them on therapies, so getting better. So I was like, I can maybe make this like, hopefully a career for myself. My own personal stuff. I mean, I went through some medical issues and I haven't been able to scope because of my medical issues. So I was like, well, if I can't scope, what am I going to do? I mean, the livelihood of most GI doctors is scoping. So then, this became the passion. The IBD became the passion because my medical disease doesn't affect my brain. So if I can still think and help people, then I'm going to do it. So that's kind of how I fell into IBD. There were mentors too. I mean, I had the opportunity with Crohn's and colitis to go to a 1-month fellowship at in San Francisco with Dr. Mahadevan and her husband, and that really kind of like solidified my interest in it. And obviously, then going to Mount Sinai, some of the big name figures that at Sinai, from Colin Bell to Dubinsky to Kornbluth. I mean, these are juggernauts in the field that I got the chance to like sit down next to, get to know them as not just superhumans, but humans. Got to know them as people, and really got to be very humbled. And it did solidify. I mean, after the fellowship, it really solidified. This is what I want to do. This is my passion, my interest, and I think the nice thing was in the military, there was nobody who did it.
Yeah.
Nobody, was selected ever in any time in military history in gastroenterology that anybody wanted to go do an IBD fellowship. So for me, it was probably more of a livelihood thing. It's like, it's one of the things like I will always have a job, number one. Number two is going to be, it was a nice niche practice. I mean, because, for me, like, I'm the only person doing this in the military, dead set 4th year trained in this one. So, it allowed me to have my agenda, which is very small, but it's more to push military medicine to the brink, and get people taken care of with it.
Mm-hmm. It's
more
still
long-winded if I wanted.
No, it's really interesting, because it takes into consideration your own personal interests, but then also the people you met along the way, and then also just other things that just set you on this path, which I'm grateful for, because there's clearly a need. I still can't believe that you're the only one.
Yeah. I mean, it's like a blessing and a curse at the same time.
Yeah.
Is that, I had mentors that pushed me to do it. And, you really kind of fought and, got the paperwork through, and they allowed me to go do it. But, the curse is I am the only one 4th-year trained. I've been very lucky because I had to train fellows every single day. And I had, one of my good colleagues, Dr. David Delaney, is with me now. I mean, he stayed on his staff. And so he is like the next, he really kind of taken on IBD with me. And then I also have fellows that have graduated other sites that are interested in IBD. So, for me, it is a bit of a curse, but it's also something we build on. Right? I think that's what it is. I mean, even though I'm the only person, but I can build on that and hopefully get more people interested in it, but also highlight the fact that the military does have these issues. They do have people that have this disease. It's a little bit of a different way we manage them when it comes to typical civilian people, and I think that's where the blessing of doing that 4th year does help with that one.
Mm-hmm. You led right into my next question, which is, what is the difference in what you do versus what is done in the civilian space for IBD?
Yeah. I mean, and that's a great question. So one of the big things we do. So, for example, if you're in the civilian sector and you got diagnosed today, you're obviously going to take into consideration your jobs and what you do, obviously. Okay. But it may not affect your livelihood. Like if you're a CEO for a corporation, you can still go on an infusion or an injectable and be fine. In the military, you can't. Mm-hmm. So if you're a pilot, for example, I can't put you on injectable therapy because they can't fly in the plane with injectables. They can't refrigerate that one. My Army folks who get deployed, if they're sleeping in tents outside, they can't. It's not like you get like a nice little like Maytag refrigerator, deployed with. So you can't keep it in the fridge. Mm-hmm. So it becomes a really big logistical thing too. And this is where the orals, help us a lot. So, for me, I have to take into consideration now obviously what they want too. I mean, obviously, if their considerations on treatment management, but also I have to be aware of what the military wants too. Remember, this is a volunteer service. Mm-hmm. So many of these folks, come in, these guys and girls come in, and this is their livelihood. They want to make a career of it. And then they get diagnosed with something debilitating like IBD. No one asked them to get it. We always have this joke in the Army is that if the Army wanted you to have something, they'll just give it to you. Okay. They'll supply it for you. Mm-hmm. No one wants to get supplied IBD. So I think that's where the big difference is. Like I need to take their career into consideration, but also military. I need to make sure they can deploy. I can make sure they can do their job, right, what they're doing. Because if we lose some people, what happens? The nation can't get protected very well. I mean, so there's a lot of, interplay with not just medical management, their job, but also career limitations and all kind of stuff that goes on that I have conversations with my buddies at the IBD centers too. It's like, every single time it's like, how are you different than anybody else than what we do? And I give them the same thing I just kind of told you. They're like, oh yeah. We didn't think about that. They go, yeah, that's right. That's my job to think about that. Yeah. So there's a little bit different spin on how we manage them with it.
Yeah, 100%. Yeah. And it makes perfect sense. But also, though, it goes beyond injectables because people with IBD need more care than just, prescribing them a drug. So how do you work with other providers in order to give your patients that holistic care that IBD patients need?
Yeah, the whole, and you hit on the big thing, Amber, is going to be this whole multidisciplinary care kind of package. And it's tough. We're military. Okay. Mm-hmm. I don't have the courtesy of an Ivy Tower where we get tons of funding and I can have a dietitian, a psychologist, and a coordinator and social worker. I get what I get, unfortunately. Mm-hmm. Okay. We were able to build an IBD center from scratch with whatever scraps I can get. So I don't have an embedded dietitian. I don't have an embedded psychologist.
Mm-hmm.
We have vetted, so we have divisions that have this. We have departments that are there. So I vetted some psychologists to help us. Nutrition's been a little bit of a tough deal. So I actually myself got selected to go to Cedars-Sinai's nutrition program, which is a year-long program. So I personally took it on my onus to be the only person in IBD in the military doing nutrition also, wow. Nutrition IBD. But part of that, obviously we can't do, we have 15, 20-minute appointments. So, and we all know we can't do everything in that whole time. So what we started doing is we started kind of farming it out a little bit. Mm-hmm. So my mentors at Mount Sinai. So this is, with Dr. Dubinsky and Dr. Kiefer, mm-hmm. They started Trellis Health. Trellis Health has been a really big game changer for us in the military, for example. It's because they take care of all the ancillaries that we don't have. Like the military won't pay for, from social working to nurse practitioners to IBD nutritionists that are trained in their program. So we have been able to offload a good chunk of patients to them to help them help us, and they co-manage it. So they're not going to sit there and go and say, oh, this patient's failing the biologic, you can change your biologic. They're taking care of the psychosocial aspect right. of the thing to help us out. Like I will do some of it in clinic, like my fellows know how to do it. I teach them how to do it, but it is, you open a Pandora's box. The one big question my fellows hate when I come into their room and to talk to a patient is, how are you doing? It is like, it's the most simple question you can ever ask somebody. Mm-hmm. An IBD patient, not so much. No. The cat comes out of the box, and then the 20-minute appointment goes into 40 minutes with that one, and we get pushed behind with that one. So a lot of it, for the first couple of years, I was doing everything, and it was tough. It's tough trying to do the nutrition, the psychology, and stuff like that. And I don't have a psychology background. I'm not a psychologist. So for me, kind of doing resiliency training, coping kind of stuff, I learned it and was very lucky to be with mentorship with Dr. Kiefer out of Sinai. But I can't do a whole session like she does. So, with her help a lot, I've done a lot of psychology with her, push a lot of people to her, independent kind of stuff. But now that they started their own platform with Trellis, it's been a huge game changer for us. Mm-hmm. So a lot of stuff we're kind of saying Roman Well is another dietary one that I do recommend patients to also. Mm-hmm. I vet a lot of these things. So a lot of these things I vet myself. I personally won't talk to them. Unfortunately, in San Antonio itself, and this is not just us. This is across the whole country. There's obviously a lack of psychological care. Yeah. Because they're inundated. But also finding somebody that's dedicated to chronic care management, and a nutritionist that's dedicated to GI kind of stuff is very hard to find. Right? For years I've been told all the time by some my colleagues at Ivy Towers is that well, you just need to go find somebody. I was like, okay, awesome. So do you want me to interview 50 people? Mm-hmm. I don't have time for this kind of stuff with that one. So we've been very lucky now that we have Trellis now. A lot of stuff we've been kind of piggybacking with them and helping us with that kind of holistic care kind of management with it. But I also, again, my military ones are very dedicated folks. So a lot of them are doing, we are very lucky at the military base. We actually have a wellness center. So a lot of them are doing yoga. We can send them out to chiropractic kind of stuff. We can send them out to acupuncture. So I will add, more complementary kind of stuff along with it too, to kind of piggyback with it too.
Mm-hmm. Yeah, I'm glad you've found those resources because you certainly don't need anything else to do in your life. It sounds like.
No, I'm never busy at all. Ever. There's no such thing.
So there's something that I have been thinking about the past several years as I've interviewed some active service people and then also some veterans who were separated from the military due to their IBD. And so I'm just wondering, what might be the difference? And can you talk about some of the things that you've seen and why people might be separated or why they might be allowed to stay?
Yeah. So great question. So I will tell you, probably 5 years ago, a lot of this changed for us. And that was because of the oral therapies.
Mm.
So like I mentioned before, if you're on an infusion or biological agent, whether it be an infusion or a injection, you can't deploy.
Yeah.
Once you say you can't deploy, automatically you go through what we call a medical board. The military, and each one, Air Force, Army, Navy, they all have their own regulations. And if you don't meet the deployment regulation, you end up going through this process. So a lot of people end up, unfortunately, you don't ask for the disease, but you need a therapy that's maybe the biological agent at that time, and you can't stay, depending on what their job was too. So there's a lot of interplay with stuff, but the basic factors tend to be what their job was. So, if, for example, if you're someone who's in a tank, works in a tank all day, the tanker, or like an F-16 pilot, you can't be on infusions and injectables. You can't sustain that. You can't be deployed on that kind of stuff. About 5 years ago, when we had the first JAK inhibitors came out, this was a game changer for us. I mean, like, mind-blowing game changer. Now that we have another 3 orals now, from 2 JAK inhibitors and 2 S1Ps, this has been a huge game changer for us. Because a lot of times what you can do now is these folks, once you get them under control and oral therapy, I can deploy them because it's a bottle. So they can literally take a 6-month shipment with them in their backpack with them. And then they can also get it. So we've gotten to the point where we've also talked to their line chain, their pharmacy chains, and say, hey, can you supply them? If they went somewhere, can you supply them this? They're like, yeah, we can. It comes in a big old shipment, and they can get it over there. So that's really been the big difference between us right now in the last 5 years with that one. The other big things play a role too, like if they had surgeries or other complications, that plays a huge role too. I mean, you can't have multiple resections, really can't have a pouch. So I've kept pouch patients, but I think the overall arching thing, you had to have an advocate. Yeah. I think that's what I learned when I was in fellowship. These folks, even though they were really adamant they wanted to stay in the military, they didn't have an advocate for themselves. Because most of the providers like, well, you have IBD based on the regulations. Well, you got to get out. We've changed it. I mean, us at Brooke Army here, my colleagues and I have changed this paradigm. Is we want to fight for you. We want to fight for the soldiers. I mean, if you want to be a job and want to do 20 years, I will find a way to fight for you. Hence, the oral therapies come in so that I can play that game, but also I will fight for you tooth and nail. I will send letters, memos, talk to their bosses, and we do. We have about a 70% retention rate in the last 6 years that we've done internally. That we've done the number. I mean, it's a mind blowing number. But it's also based on it's not like 1,000 patients. It's still a small number that get that realm, but we're very good at it because we want to be advocates. I mean, a lot of places may not be comfortable treating IBD, or they just really don't understand the implications of regulation. So, do I push the envelope? Of course I do. But I push it not to hurt them, but I also don't want to hurt the military. Because I obviously don't want to deploy somebody if they're really sick and they get sick downrange. Yeah. Like they're in the middle of like Afghanistan, Iraq, or wherever it happens, and they get sick. I'm putting everybody at risk. So, but these are conversations I have in my clinic. These are questions like kind of piggybacking your old question, the difference between us and civilians. This is part of it too. Yeah. Is like, I had that conversation with the patient. Like, look, if I put you on this therapy, you might not be able to do this. Might be able to do this. It might close some doors for you, but it may open some other doors. So I think that's where the big dichotomy comes into play. I mean, it's hopefully changing soon. Like over the next couple of years, I think we're going to see a paradigm shift only because we train a lot of the fellows in the military and they train with me and my colleagues, and they see what we're doing. So a lot of them will go to other bases. Like for example, I just went out to Traverse Air Force Base out in California and was talking to them about this kind of stuff, and they're like mind blown. Like, what? I can keep pilots on this stuff? Like, yeah. Like, oh, this is phenomenal. I mean, so this has been the nice, the blessing again, is that, I have the ability to go out to these other places and teach them what we're doing at our institution, and getting these people to stay on, letting them do their jobs, and letting them have full careers in the military. I mean, I have 2 to 3 star generals all the way down to like lower enlisted E1s and E2s. Obviously, as you're at the unfortunately kind of at the lower end, like E1s, kind of at the lower enlisted or officers, is a little bit of a difference. Again, that's like the minutia, which I won't get too much into. It all depends on their job and that kind of stuff. But yeah, but I think we're hoping to try to make policy changes too. I mean, this is something that we're fighting with, with people up at the Pentagon and that kind of stuff. And my colleagues are trying to fight to change some of these regulations, which are old.
Yeah.
They're old. They don't take into account many of these drugs. So we want to change the regulations so we don't have this happen where we have a lot more people leaving who want to stay in. People will fight for them and be able to be on oral therapy and still be able to be successful in their career with it.
Yeah, and with these newer oral therapies, some of them might be difficult to get for those of us that are on private insurance in the civilian space. How does that work for active military?
Yeah, so that's a sneaky question. Remember, it's a sneaky question. Sneaky. I like it. So we're funded. Remember, so we the military medical system is a funded system, right? A lot of times these oral therapies, we do have opportunities to get them first line because of this reason.
Okay.
Is that I will talk to the pharmacy. I will talk to, TRICARE, whoever the insurance carriers are, when we do it, and personally talk to them and say, look, I need the oral therapies. I need to put them on first line oral therapies because I need them to stay active duty. Mm-hmm. If I pull between, typical military lingo, mission capable or mission non-capable, what happens? If I tell them, well, you know what? I have this, high-ranking person who's phenomenal, high general, but I need the oral. Otherwise, if I put them on like an injectable or infusion, they can't stay in the military anymore. How can I stay by? Mm-hmm. So what we have done, and this is part of the progress that we've done, the fight we've done for the last 5 years, is be able to get these first line, be able to get these JAK inhibitors, S1Ps. That yes, you are correct. In the real world, it's very difficult to get them first line. Mm-hmm. We have strategized and been very lucky to have phenomenal, leaders in both the pharmacy, both inpatient, outpatient pharmacy, but also leadership above that's fully supported what we're doing. It's more than knocking down bricks. I literally just had to knock down bricks one by one and find it, and really kind of use that whole spiel that these are military folks. I got to keep them active. And the one thing to do is orals. And we haven't had to knock on a wood desk here. Knock on wood. I haven't had any issues so far with that one.
Yeah. It just makes a lot of sense. So I would hope so. I would hope that there's not as many
fingers crossed
hoops that other people might have, because it just makes sense. So I have talked to a few different veterans who transitioned, okay? And this was usually because they were diagnosed with IBD, and then they were separated from service, and then they had to transfer and, learn how to manage the condition, also while learning how to receive care in a different system. So I'm wondering what kind of advice or tips that you have for people who might be going through that.
Yeah, so this is a great point. So it's funny enough, we actually did a study on this. So I actually was able to get a small grant to do a study looking at transitioning. Mm-hmm. So what I would always notice, especially people came and saw me, was that their health literacy was very low. Because part of it, when I asked them what happened, was like, you're whether you be 21, 20, however old you were, you get the diagnosis. What happens? It's like getting the cancer diagnosis. It's like, oh, you have UC, and everything else goes through your head. Over your head, and you're like, oh, how am I going to live my life? How am I going to do? And they forget about everything else around it. So I started learning that, I need to start educating these people. I need to start educating these soldiers, especially then when we're transitioning out. So the study I did was looking at the military has its own transition process. It's a standard way they do. Every single person, every single military sector does this. It's a 1 week long process. It's not very medically oriented. There's some VA kind of stuff, but it doesn't go through your diagnosis. So I split patients into doing that regular stuff and then doing that plus me. We have surveys like see what areas of their medical health literacy and that kind of stuff they were lacking, and we did extra education on that one. So we noticed we saw obviously a big spread. We saw people who were more health literate, or had more resiliency or coping skills that they got out of the military, as opposed to ones who did not have the same training. Mm-hmm. And then we will follow them 3 or 6 months after they got out of the military. And, many of them flared, unfortunately, because of some VA issues. But even though the ones I give teachings to, they still maintain resilience and coping. They're able to manage their care without having to be like, having the detrimental consequences of it. So what we started doing, we actually have a transition clinic. So we actually, part of our IBD clinic, those who we know are transitioning, we typically will see them, we know 6 months out they're going to be transitioning.
Yeah.
We may not know the exact date, but within that time frame, I start the conversation. Okay, hey, what is your plan? What are you going to be doing? Do you even know where you're going to be going? Where are you going to be living? What VA's near you? I start that conversation. About 3 months before they're getting out, I really solidify it. Okay, what state you going to? Who you living with? What's your job going to be? Where are you going to get the insurance at? Where are you going to get all that kind of stuff at? And then, a month before they get out, we do the same thing. And that one, I really want solidified answers with that one. A lot of times, once they get their DD-214, which is the paperwork to say that they're out of the military, we still let them have contact with us. So many of them will have like my email address. Very select few have my cell phone number. So whether they're transitioning, if they're having issues, they can email us directly and have contact with us still, and I can give them some more advice. What we noticed and the problem is that even though we gave them good, health literacy, coping skills, all that kind of stuff, we still had a gap between getting out of the military and the VA kind of stuff. And that's a work in progress that we're trying to work through. That there's still lacks of, limited access, care, depending where they go. Obviously, if they're going to a big Mecca city, IBD care is going to be easier in the VA. When you go to like small little places, you may not get the care. And a lot of them, like wait times are like 8 weeks to 10 weeks to see a primary care doctor who has to put the consult for GI. So it's not like you can go straight to GI when you get out of the military. You have to go straight first primary care, then GI. And whether or not they have GI there or not. And so there's a lot of delays that happen in the back end after they get out of the military with that one. And a lot of that stuff is, for me, what we're trying to do now is trying to approach that earlier. Is trying to break that harm and that break and figure out where they're going, try to find a way to be the liaison between us and the VA and get them in. We've done a lot with San Antonio VA. I mean, I work with them. I know the docs very, very well. So we're doing a lot of transitioning between, if they stay in San Antonio, I will do a lot between them. Here in Austin also, I do a good chunk up there just to kind of have that continuity between them. But it is, I mean, the once you get into the VA system, it's a very, I don't want to say broken because it's not the right word I'm thinking of, but I can't remember. It's a very disjointed system.
Yeah.
Because there are great IBD centers. Don't get me wrong. There's some phenomenal IBD centers within the VA, but they're like East Coast or West Coast.
Right.
The whole part of the middle of the U.S. is a big glut. And most human beings and most military people, for the most part, are in the glut.
Yeah.
So it becomes a very difficult scenario, but a lot of times I tell them, be advocates for yourselves. I mean, I've done it where I told people, bang the doors down, literally be the jerk, be a jerk with that one. I mean, it sounds awful. No, it's awful. The doctor's saying this one because I've been on the other end. I've been on the other end. Patients being jerks to me, being a pain in the butt with that one. But for me, this is your care and your livelihood. This is IBD.
Yeah.
Okay. The last thing you want is a flare.
Yeah.
And flare, because what happens when you're controlling the military, because we have pride in what we do. In the military, we have pride in getting these people. We don't want to let them leave until they get control of their disease. Whichever, whether it be medical therapy, surgical, whatever it be. We don't want them to leave and go and be in this gray zone and say, well, the military had me half covered or half controlled. Now I wait for the VA and I don't know when I'm going to get in the VA. So we don't want that. We don't want that gap. With that one, but a lot of times what I tell the veterans is, and Crohn's Colitis has done a great job. So Crohn's Colitis actually has a website for veterans. Actually, if you just Google Crohn's Colitis veterans, there's actually a whole website that I help Crohn's Colitis help develop. My ugly mugs actually on as a video on there too. So you have to hear me again if you want to, painfully. At that time, you have some alcohol too with that one. But it has a great. I mean, so I help them kind of spearhead, the assets there, the handouts, that kind of stuff to help them guide them through the VA debacle sometimes.
So we talked about oral therapies and how that's been a game changer. I actually didn't realize. I knew that it would be, but I didn't realize how big of one it would be. Is there anything else that's being researched, anything you're researching or anyone else is doing that may help any of these processes, either keeping people, retaining them, or helping them as they transition and avoiding flare-ups during that gap time that they have?
Yeah, we were surprised too. We were literally surprised how much we're going to use. Like, I literally have no idea. Like in the last 2 years, we've used a lot of the oral therapies. And I didn't realize how much we were going to use. Like when they first came out, I was like, I don't know if people are going to use it or not. People are so used to infusions and injectables. Once we started dabbling and realizing that, oh my goodness, like we can do like mind-blowing things with these drugs, not only just from an efficacy standpoint, but also from like a duty standpoint. Like they were doing great. I mean, what we're looking at in the pipeline really is the orals. Like, essentially what we're looking for is obviously, what everyone's looking for. Okay. The drug that is the most effective and that's the safest, more likely oral is what we're looking for in the military segment. Okay. That's a common sense one. The one big area that we're still struggling with in the military, and I think that's what civilian too, is perianal disease. Unfortunately, we just had one drug that was very hopeful, that unfortunately did not make the FDA cut, which is very frustrating. With that one, it has approval in the EU and Japan, but just didn't make it our cut for some reason. That was detrimental. I mean, that to me was like literally. I mean, there was a lot of curse words that night when I saw that statement that came out. I was very, very angry. I mean, I had a lot of patients that were looking forward to it. So I think that's where an area that's still a big gray zone. I think the orals coming out of pipeline, they're going to be magical for us. Like, I mean, magical with that one. We're using it right now. And I mean, if they get safer, more efficacious, I mean, that's going to be our juggernaut. I mean, that's going to be our first line therapy. I mean, we're using the first line, but that'll be our juggernaut workhorses. But I think the pipeline still needs a very good perianal disease therapy. I think that's what we're still lacking. Our personal research, I mean, we do a lot of clinical research. We do some clinical trials. But my area is really my need and my fun is clinical research. I mean, for what my colleagues want to do is we want to advance science. Yeah, this is our whole goal. I mean, so a lot. I work with a consortium with a bunch of IBD centers, like my own colleagues. Around the same level as me, around all IBD centers around the whole country. Okay, we call it remote IBD is the name of it. So a bunch of centers from like Mount Sinai to Washington University, Wisconsin. That's just name a few of them. I mean, I know I'm leaving out a bunch of them, but we've all got together, egos aside, and we just said, look, we want to put data out there. We want to put data like on these new JAK inhibitors, real world data. We want to put it on the new S1Ps, on the new IL-23s. We want to do this, and we can do it in big volume without having the cronies of a crony, or having having these egos kind of play a big role in there. And that's what we've done. And what we're doing, I mean, we have a couple posters coming at DW, hopefully here next year. I mean, so and that's what we really push the envelope for. But also what we're going to do, part of our internal kind of research, looking at the active duty model, looking at we don't have DI problems. Like we don't have problems with racially, insensitive problems. Like everyone gets equal care in a funded system. So we've done abstracts. We're going to be publishing a paper on this one. Looking at the cost of stuff. We're looking at cost savings. How is it in one system can we save? I mean, we went biosimilars for infliximab, and we saved $2.1 million in 1 year. Oh my gosh. Published that stuff. I mean, so we want to be able to show in a system-based model. Even though it's a funded system, we can show changes. We can show improvements, but also showing that we're going to do some prevalence. I mean, we're doing a bunch of studies in the IBD realm to show that military IBD is here. We have people handling and managing it, but we can be very aggressive and showing. Like our whole goal is to show that if you're aggressive early, long-term management is better. But also using these advanced therapies like oral therapies first. Yeah. Proving that point. Like, screw the FDA with all this stuff. It's like you got to step through. We want to bypass it. We want to say, look, you don't have to. If you go straight to the big juggernauts up front and people who really need it, you're going to save money in the long run. You're going to save time. You're going to help the patient. So I think that's what we really kind of push and strive for when it comes to the research side with us.
Yeah. And so many people, of course, would agree with you.
Yes, no, I know, Amber. Trust me, I know. I have the ones that leave the military, and the first words are many curse words. Yeah. I can't say them on the podcast. We might be bleeping me out a little bit.
I'd be bleeping you.
Bleeping me out. But they are. I mean, they literally leave and they go to the civilian sector because either they lose their military, their spouse, they don't get the extra care, right? Or they don't have the military benefits, and they're stuck. They're in the glut. Yeah. They're like, look, I mean, I can get these things here, but I can't get them now. I'm like, unfortunately, this is how our insurance is. Our insurance is just not not built to help people, unfortunately. It's just sad enough to say, I'm a big believer. I mean, I'm in a system that's a funded system. I believe in the insurance platform, but it's not doing right by people, and I think we're failing people a lot, unfortunately.
Yeah, I agree with you. And
Yeah.
in the interest of not failing people, you already mentioned that Crohn's and Colitis Foundation does have a section of their website dedicated to veteran. I don't know if it's veterans or active military or
Veterans.
both. Okay.
Veterans. For veterans, yep.
Okay. I believe that they also have a Facebook group. Do you know of anything else, or is there anything else that you send your patients to?
Yeah. So actually, Crohn's and colitis, and I believe I have to look at it again. I think it's on the veteran website. They actually do have support groups.
Right.
So the military there's actually a couple of states kind of got together, and these are spouses of active duty people that actually got together and did a support group.
Okay.
I can see, I can email it to you if you want to put it up on
because I'll put it in the show notes.
On the website.
Yeah.
I can send you that flyer that came through from them. So there is a support group for military folks, but also their spouses also. The Facebook ones are still there at Facebook.
Yeah.
I think the Crohn's veteran website is a big one. There are some local, there's not like a dedicated military one. I think that's what we're trying to get. And I think Crohn's did a great job of having this one start with that one, but we're trying to also do it in our own system within the military system. We try to find like a global virtual support group that we can do within the military system. And that's something that's, I'm hoping, it's in very, very, very early progress with that one. I mean, we're probably looking at another year or so that we can get something like that together. A lot of this is going to be just kind of like talking to the providers. If you're active duty, you're talking to your provider and getting kind of the know-how. But also, if you're active duty and you're seeing active duty provider, they'll have access to us at Brooke Army Medical Center.
Okay.
They can always email us, message us within the medical record system, and we are more than happy to be supportive. We're more than happy to be, I'm more than happy to give a phone call to somebody I get a message from or email from. I've done it already. I mean, I've gotten emails from people from like families from Tripler that were coming back to San Antonio. I just got an email earlier today that I have to answer back. Like, hey, I have family members or I have friends that have this disease. They're coming into the city. What can you help them with? And I haven't seen these patients in like years. That I've never seen them before. And I'm more than happy. Like, for me, it had nothing to do with money, pride, or anything like that. To me when what I've learned a long time ago, and it took me a while to kind of really understand this one as I stayed longer in the military, is that putting the uniform is very prideful. You get a lot of pride in doing it. I mean, I think that's why my wife and I are still in the military. My wife is a gynecologist in the military, and I think it's very humbling when you go in, walk in the doors, you have a uniform on, you get to see somebody in uniform, and you get to help them with their career, get to help them, but also help their family too.
Yes.
Because say for example, if the spouse is the one afflicted, not the active duty person, but you give them a backup, you give them a life. Because what's the first thing that person's going to worry when they get deployed? What's happened to my spouse? Or they're going to go to the hospital again, or they're going to get surgery without me being here. So I think this is where we've come and said that, this is not a pride thing. This is something that we want to help. We want to help everybody we can. Like, trust me, like, I would love to have like we have about probably 100,000 soldiers that have this disease with that one. I would love to help every single one of them if we could. I have my pride is not that big. I mean, I seriously, this is what we do. And then not just because I'm on this podcast with you, my fellows, my staff, my colleagues can tell you the same thing. I don't change. I don't change when I leave here. I leave this podcast. I don't change when I go to my office. My fellows see when I see the patients in the office with that one. I mean, our goal is to help soldiers. This is what we put the uniform on. This is why I have the flag on the right-hand side on my arm. Is to help these people and get them to the point where they're not scared to leave. They're not scared to do anything with that one.
Yeah. And military spouses, gosh, that's a whole other topic
that's
for another episode.
Podcast,
yeah.
Amber.
Yeah.
Yes.
Oof, all right.
Yeah.
I'm gonna put it on my short list. You've talked about so many things and opened my eyes, and of course the listeners as well as they're hearing this. Do you have any general advice, any last tips that you have for anybody who's active military or veteran who's living with IBD?
Yeah, and I always do these. Like a two-pronged thing, okay? One's going to be have hope, okay? Don't lose the hope. Even if doors close on you in certain ways, don't lose the hope, because there's always going to be people that are going to help you, okay? So don't ever lose hope. The second thing is be your advocate. Like I mentioned before, be an advocate. If you have the hope, you're an advocate for yourself, things will get better. And this is what every single person that leaves the military, this is the last line I leave them with. Exactly what I just told you, I leave them with every single one of them, is have hope and be an advocate. Those are two big things I think I believe in. I still to myself, I do it myself. I'm a big believer in it with that one, but I also want them to believe in it too, that hope is not lost when you leave the military.
I love that.
Yeah.
Dr. Patel, you're a busy person. You've taken a lot on. But I'm wondering, what do you do for fun in the 5 minutes a week you have in your spare time?
Oh my gosh, Amber. So I'm a big sports guy. You asked me before what my favorite color was. So big football, baseball, basketball. My wife and I go to Spurs games a lot here in San Antonio. I have a 6 and 4-year-old, so they take a lot of my time. With that one. So, hanging out with them, I'm simple. Like I'm about to tell you, like I'm like a hermit. When I get home, I just want to sit around, have a little thing of whiskey and watch my Netflix. Have a camper, like very simple and easy. I'm a big sports guy. For me, sports is like kind of like my saving grace. Now the Giants stink this year, so I can't. They're frustrating, so they don't help me a lot. With that one, but I do. For me, it's the family. The way I can do what I do now and the way, give me the ability to be an advocate and have this access and be able to do things like this with you is my family. Everyone always says it takes a village and I believe in it. I have, my kids are amazing little kids. My wife is probably the biggest saint in the world. I think she's an amazing soldier, but she's a doctor, a phenomenal mother, my best friend, my soulmate. She's the one that probably brings it all together. My parents, my in-laws, my brother, like all these ones have really kind of built and helped me build this platform that we have. And I think this is where I show. My family comes in my office. My whole clinic knows my children. They come every single Halloween, every single Thanksgiving, every single Christmas, and Easter. They hang out candy to everybody. We give them candy. They hang out candy to everyone in the house, random people, and they love it. But I want them to know that I do have a human side. And it is my family. My family is probably the number one thing that drives me to do this kind of stuff and have the passion I do is them with it.
Well, when I reached out to you, you said yes to me right away, and which was amazing. And so I understand now how you are probably a lot of people's first go-to when they have a problem, because you're a yes man. You're going to say yes, and you're going to help people. Yeah.
Yep.
So, well, on behalf of everyone who lives with IBD, because what you do is not only helping the patients in front of you, it's also helping all of the rest of us, especially with the research. So thank you so much for doing all of that and for helping your individual patients who are active military. I don't think they could ask for a better advocate. And thanks for talking with me today.
Well, thanks for having me, Amber. I really appreciate it. This is a great opportunity. Love it. Love to do it again in the future.
Oh, well, I'm going to hold you to that. So
I'm in.
Hey, super listener. Thanks to Dr. Anish Patel for taking time from his busy schedule to talk to me. What he's doing is so important because it is creating change for people with IBD both in the military and outside of it. Plus, it was really fun to connect with him and talk about not only these important issues, but also our mutual love of a good whiskey. November is National Veterans and Military Families Month. November 11th each year is Veterans Day. I'm including a number of links to information and resources for active service people and for veterans in the show notes. The Veterans Crisis Line is available 24/7 by dialing 988 and pressing 1, by sending a text to 838-255, or by chat at veteranscrisisline.net. Plus, as always, links to a written transcript, everyone's social media handles, and more information on the topics we discussed is in the show notes and on my episode 141 page on aboutibd.com. Thanks for listening. And remember, until next time, I want you to know more about IBD. About IBD is a production of Mal and Hal Enterprises. It is written, produced, and directed by me, Amber Tresca. Mix and sound design is by Mac Cooney. Theme music is from Cooney Studio.